Hello everyone. Welcome to our module on the renal system. In this module, we will talk about the kidney cancer and the bladder cancer, that is the renal neoplasia. So let us start with the first and the most common kind of carcinoma in the kidney, that is the renal cell carcinoma. Okay? Now, what are the findings of renal cell carcinoma? There are polygonal clear cells filled with lipids and carbohydrates. So there are polygonal clear cells. Hence, it is also called as clear cell carcinoma. Okay, so due to polygonal clear cells which are filled with lipids and carbohydrates, it is called as clear cell carcinoma. You can look in this image. In this image, there are clear cells with accumulation of lipids and carbohydrates. Now, it is often golden yellow due to increased lipid content, which is visible in this gross diagram. You can look at this gross specimen where there is renal cell carcinoma, and hence there is golden yellow color due to increased lipid content. In the microscopic image, there are clear cells with lipid content. Is it clear? Now, from where does it originate? Renal cell carcinoma primarily originates from the proximal convoluted tubule. Okay, so from the proximal convoluted tubule, it invades into the renal vein and then into the inferior vena cava. Now, from the renal vein to the inferior, from the renal vein to the inferior vena cava, through the inferior vena cava, it leads to hematogenous spread. Is it clear? Now, through the hematogenous spread or through the blood, the renal cell carcinoma metastasizes and hence reaches the lung or the bone. Is it clear? So, it originates from the proximal convoluted tubule, invades the renal vein, and then goes into the inferior vena cava. Then, through hematogenous spread, it metastasizes to lung and bone. Now, since it invades into the renal vein, if it invades in the left renal vein, then it can lead to development of a varicocele. Is it clear? Now, it manifests with three kinds of symptom primarily, that is hematuria, palpable mass, and flank pain. Okay. Now, it can also be presented with secondary polycythemia, fever, or weight loss, since these are paraneoplastic syndrome which are associated with renal cell carcinoma. So it is primarily presented with hematuria, palpable mass, and flank pain. It can also be presented with paraneoplastic syndrome, that is fever, polycythemia, and weight loss. Okay. Now, what is the treatment? The treatment is surgery or the ablation of the localized disease. That means if there is a carcinoma just restricted to this part of the kidney, then it has to be resected. Okay. But if it has metastasized, then it can be only treated with chemotherapy and radiation therapy. Okay, but if it is majority of the renal cell carcinoma are resistant to chemotherapy and radiation therapy, and hence immunotherapy, example aldesleukin or targeted therapy for metastatic diseases are given. It is very rare that it can be cured completely, and hence it is one of the leading cause of death in carcinomas. It is the most common and primary renal malignancy and is associated with men around the age of 50 to 70 years old. There is a very increased incidence with smoking and obesity. Okay. Now, since it is associated with paraneoplastic syndrome, example hypothyroidism, then ectopic erythropoietin, that is excessive production or decreased production of erythropoietin, ACTH, renin, hence it produces symptoms of them as well. Is it clear? Now, clear cell carcinoma is associated with gene deletion of chromosome 3. Okay, hence it is sporadic. It can be sporadic due to smoking and obesity, or can be inherited as VHL syndrome, that is von Hippel-Lindau syndrome. Is it clear? It is associated primarily with chromosome number 3. Am I clear? Let us go to the next type of carcinoma, that is the renal oncocytoma. The previous one we discussed was a malignant cancer, whereas this one is a benign epithelial cell tumor. It is a benign epithelial cell tumor which doesn't metastasize and arises from the collecting duct. So, if there is a clinical presentation in which a cancer has been originated in the renal system from the collecting duct, it can be renal oncocytoma. Is it clear? Let me just show you how the renal oncocytoma looks like. You can look at this discoloration. This is the primary renal oncocytoma. Okay. It has a central scar and has peripheral tissue damage. Is it clear? Now it is largely eosinophilic with abundant mitochondria without perinuclear clearing. You can look in this diagram in the histology that in the oncocytoma, it is largely eosinophilic without perinuclear clearing. That means there is no perinuclear clearance. This is the normal histology or the normal tubules, whereas this is the oncocytoma which has excessive amount of eosinophils. Okay, and there are extremely high amount of mitochondria as well. Is it clear? Now, what is the presentation of renal oncocytoma? It is presented again with painless hematuria, flank pain, and abdominal mass. Okay, the primary distinguishing feature is that it arises from the collecting tubule, and on histology we can see abundant mitochondria without perinuclear clearing and excessive amount of eosinophilic cells. Is it clear? Now, what is the treatment or the cure of renal oncocytoma? Since it is a benign tumor, it is just resected. This part is resected from the kidney to exclude the malignancy, example, the renal cell carcinoma. If it is not resected, it can lead to renal cell carcinoma and become malignant. Is it clear? Now, let us talk about nephroblastoma. Nephroblastoma is also called as the Wilms tumor. It is also called as Wilms tumor and is most common renal malignancy of early childhood. That means a child having renal cancer can be most likely due to nephroblastoma or Wilms tumor. Is it clear? Now, what does nephroblastoma has? It contains embryonic glomerular structures, one, and it is presented with a large, palpable, unilateral flank mass. That means if you can look into the CT scan, this is the nephroblastoma, and hence this is large, one-sided, and hence unilateral and abdominal mass, which is presented with unilateral flank pain. Okay. There is hematuria and possible hypertension, but it is not compulsory that hematuria is always associated with nephroblastoma. Is it clear? Now, it is due to loss of the function or the mutation of the tumor suppressor gene, that is WT1 or the William tumor 1 or WT2, which is present on chromosome number 11. Renal cell carcinoma was due to VHL factor present on chromosome number, correct, 3. And nephroblastoma is due to mutation of tumor suppressor gene, that is WT1 and WT2 on the chromosome number 11. Is it clear? Now, it may be presented with several syndromes. Okay, this is not associated just like that. It can be presented with multiple syndromes, which are WAGR complex, that is Wilms tumor, aniridia, that is the absence of iris. Then there can be genitourinary malformation, mental retardation, or intellectual disability. Now, this happens when there is a deletion of WT1 gene, and hence it is presented as a WAGR complex. Is that clear? It can be also associated with Denys-Drash syndrome. Now, what is Denys-Drash syndrome? It is Wilms tumor. Then there is diffuse mesangial sclerosis, that is very early onset of nephrotic syndrome. In nephrotic syndrome, there is sclerosis of the mesangium, and hence it can be presented with diffuse mesangial sclerosis. There can be dysgenesis of gonads, that is male pseudohermaphroditism. Okay, so there can be dysgenesis of gonads. This is primarily due to WT1 mutation. Is it clear? I'll again repeat about the Denys-Drass syndrome. It is presented with Wilms tumor, diffuse mesangial sclerosis, and dysgenesis of gonads. This presented if there is dysgenesis of gonads in male, it can be presented with pseudohermaphrodite, and hence it can lead to Denys-Drass syndrome. It is primarily caused due to WT1 mutation. WAGR complex is presented with WT1 deletion. Please mark this. This is deletion and this is mutation. Okay, and the last one is the Beckwith-Wiedemann syndrome. Okay, it is the Beckwith-Wiedemann syndrome. It is presented with Wilms tumor, macroglossia, organomegaly, hemihyperplasia, and omphalocele. This is an extreme and a high important because it is associated with WT2 mutation, unlike the other two which are related to WT1 mutation. Is it clear? So, Wilms tumor is often associated with a lot of other syndromes as well, and hence presented in a complex disorder. Is it clear? Now, let us go to the bladder cancer. Okay. The first and the most common kind of cancer of the urinary bladder, which is also called as transitional cell carcinoma, is a urothelial cancer of urinary bladder. It is a urothelial carcinoma of the bladder. It is also called as the transitional cell carcinoma. Is it clear? Now, it is the most common tumor of the urinary tract system and can occur in different places of the urinary tract. For example, it can occur in the renal calyces, it can occur in the renal pelvis, it can travel through and occur in the ureters and then in the bladder. Is it clear? Now, this is how it exactly looks like. This is the urothelial carcinoma or the transitional cell carcinoma. Now, it can be associated with problems like phenacetin use, smoking, aniline dyes, and cyclophosphamide. Now, these are the maximum associations or the most likely associations of urothelial carcinoma. That is phenacetin, smoking, aniline dye, and cyclophosphamide. Is it clear? We can look at the histology part. There is dysplastic urothelium over here, and there is fibrovascular core in the papillary tumor. You can look at this part. This is the fibrovascular core in the papillary tumor. Is it clear? Now let us talk about the second type of urinary bladder cancer, that is the squamous cell carcinoma. Okay. Talking about squamous cell carcinoma, it is a chronic irritation of the urinary bladder, squamous metaplasia, and dysplasia and squamous cell carcinoma. So what happens is, due to chronic irritation of the urinary bladder, there can be metaplasia, right? Now, due to the change in the epithelium, it can lead to dysplasia and squamous cell carcinoma. This is how most of the squamous cell carcinoma generate. Okay, now what is the risk factor which includes squamous cell carcinoma? The major risk factor of squamous cell carcinoma is infection of Cystoma hematobulum. Okay, now this is a microbe which infects the bladder, which is usually in the Middle East, and hence is a major cause of squamous cell carcinoma. It is often associated with chronic cystitis, smoking, chronic nephrolithiasis, and is presented with painless hematuria. There are no casts present in the urine. Is it clear? So this is all about the renal cancer and the bladder cancer. Thank you for watching this video. If you enjoyed the video, please click on the like button and do subscribe to this channel. Let me know in the comment section below which topics do you want me to explain. Thank you.